your words of wisdom as we start off this series. Karibu PS.
Thank you, Zainab, and thank you, team. I'm delighted to join you this morning to open this very important forum. This is a forum that we've planned in line with the rollout of the UHC program or implementation. As you're aware, where we are now currently is that we are reached a stage where we need all the stakeholders to play their role specifically when it comes to delivery of the UHC. Key is that we want to ensure that details are now captured because we have configured our system in a way that we are going to pick the data afresh and therefore updating the website, updating the portal, the employer portal specifically is really key, because if you do not update the employer portal, you realize that your employees will be left behind.
Yeah. Feels there's a challenge on your end, sir. When appears we seem to have lost you. Dr. Zainab, we have lost the PPS.
Mr. Ngodo, what is happening? We have lost the PS.
He's back.
Okay, Karibu PS, continue.
So, thank you. I think we have challenges, but I was saying that we need to take this exercise very, very serious and ensure that we are compliant by 20th. The directive from our head of public service was that all of us should have been onboarded by the 15th. But I think it is important that because most of you are not sensitized, we take the exercise now seriously so that we're able to conclude this process. I want to wish you success. I think the team is here. They are competent enough. They will be able to ensure that. Hello?
We can hear you, sir.
Okay, good. You know, these gadgets. So I want to leave you with a competent team. They will take you through, ask all questions that you have so that you'll be able to understand on the process that we want you to undertake. Thank you and have a fruitful discussion.
Thank you. Thank you, PS, and thank you for putting us on the way of starting off this seminar. I would like to hand over back to Mr. Ngodo. Please, back to you.
Thank you very much, Dr. Zainab. Mr. Oscar, maybe you could pick up from there and invite the presenters for today.
Thank you, Mr. Ngoto. So participants, we are now ready for the presentations, and we've lined up 3 presentations. The first will be on legal provisions, which will be done by Mr. Nyarango. This will be followed by a presentation on the benefits package to be done by Mr. Otieno. The 2 presentations will prepare the participants on how to navigate through the employer portal, which will be done by Mr. Osoro. So kindly allow me to invite Bwana Nyarango to make the first presentation. Bwana Nyarango, welcome.
Good morning. Thank you very much, Mr. Moga, for the introduction. My name is Achi Nyarango from the Legal Services Directorate. I'll be taking through a brief overview of the legal provisions that are guiding us in the registration of contributors to Social Health Authority, as well as how the contributions are going to be made and what benefits have been set out in the law for the beneficiaries of Social Health Authority. I hope the screen is visible to everyone and everyone is able to see the presentation. Okay, thank you. I will proceed. So the acts and the regulations are the two main laws that are guiding Social Health Authority in its work. There's a Social Health Insurance Act that was passed last year in October and came into effect in November of that year. So it's been in effect almost for 12 months. By next month, it will be the 12th month of operation or enactment of this law. So under that act, there are regulations that were made this year, and they came into effect on 1st of October. These regulations, the act, deal with how the authority will operate and how the funds which fall under that authority are also going to operate. So the first fund I'll talk about is the Primary Healthcare Fund and the regulations that are there. There's also the Social Health Insurance Fund and the Emergency, Chronic, and Critical Illness Fund. So those are the three funds that the Social Health Authority is managing. The regulations also deal with how hospitals will be brought on board through empowerment and contracting. They also deal with how people will be registered as members and as beneficiaries of the Social Health Authority, and the benefits under that authority, and how much will be paid to the healthcare providers for treatment that is given to beneficiaries. Finally, the regulations also deal with the claim settlement as well as general provisions. Then there's one thing that was new that was introduced by the Social Health Insurance Act, which is a dispute resolution tribunal. So there's a separate group of regulations that talk about how this tribunal will be set up and how it will function. So any complaints that a beneficiary or healthcare provider or anyone else might have with the Social Health Authority will go to this tribunal. So for this presentation, I'll focus more on the general regulations because those are most relevant to yourselves as HR practitioners and to the topic of today. Starting with the Primary Healthcare Fund, this fund is mostly going to be receiving monies from the Exchequer. So it will be appropriations by the National Assembly that will be used to fund the Primary Healthcare Fund, and it will be purchasing healthcare services for primary healthcare facilities. So these primary healthcare facilities are mostly the level 2 and level 3 facilities. That is everything from dispensary to health centers to medical centers in the private sector. And it will be both private, faith-based, and public facilities who will be accessible to beneficiaries. So it's mostly for those treatments that are dealt with as outpatient visits, including any consultations that are outpatient. And the only requirement for access is that the beneficiary will have to be registered under the Social Health Insurance Fund. So because this is not the contribution fund, the requirement is that the person must be registered in order to access. Then if the person needs additional treatment above level 2 or 3 facilities, they can then be referred to a level 4, 5, or 6 healthcare provider. That is to a sub-county level hospital, to a county referral hospital, or even to a national hospital at level 6, like a KU teaching and referral, or Moi teaching and referral, or Kenyatta National Hospital. So what services are offered under primary healthcare? These will include promotive services under the regulations, preventive services, curative services, rehabilitative services, palliative care services, and referral, as I said, to higher level facilities for specialized treatment. The other fund that is created is the Social Health Insurance Fund. So this is now what we call the contribution fund. And here the requirement is that not only will you as a member need to be registered, but you also need to be making contributions. So for the employed, it will be a deduction from the payslip, which is then remitted to the Social Health Insurance Fund for the Social Health Authority to now use that to pay for your treatment. For those who are not in employment, who maybe are running their own business or who are farmers, for example, they will be making contributions as well, but they will be making it in a slightly different way, which I'll discuss later. And then for those who are unable to contribute because maybe they are too poor, or as a result of being maybe vulnerable, or because they are elderly or orphaned and in children's homes, the government will be making contributions on their behalf, and it will be through appropriations from the National Assembly. So this is the fund that will be used to purchase healthcare at the level 4, 5, and 6 levels of facilities. So I've mentioned severally that you need to be registered in order to take advantage of this healthcare. What is required to be registered? So to apply for registration, it's important that the applicant has the national identification number and card copy. If it's a refugee, they'll need a copy of the refugee identification. There are several types which are set out in the regulation, but any of those will be acceptable for registration of refugees. For a foreigner who has been in Kenya for more than So for a refugee, I kindly request everyone. So for a foreigner who has been resident in Kenya for more than 12 months, they also need to register, because the Act says that everyone who is resident in Kenya must have health insurance. So even for foreigners who are here for more than 12 months, they will need to get health insurance, and they can use the alien ID or work permit to register. Once you have those documents, they'll need to do the application form, fill in the application form. This can be done either online through the website or through *147# using the USSD. After filling that application, they will be issued with a social health insurance number. They can then have the biometric data taken, which is now the final step, at a designated service point. This will either be this can either be the Huduma centers or the SHA registrations that will have been identified. So with that, person can register. Now for children, because it's not just the contributor who is registered, but also the dependents who are under their cover. So for children, it will be a bit more slightly different process because of the nature of the child. As they get older, some things will change. So the Social Health Insurance Act says that all children must be registered from birth. And what the regulations now say is that within 14 days of the birth of a child, the parent or guardian must apply to Social Health Authority to register that child. For that registration, they need to have the birth notification. So if it's within the 14 days, they need to show the birth notification. If the child is more than 6 months old, then they will have to come with the birth certificate. And the difference is just because it is recognized that it can take time to get a birth certificate, and there's sometimes administrative challenges in getting one in good time. So for at least the first 6 months, the birth notification can be used. Once that child the application is made for the child to be added to the member's cover, they'll be assigned a minor social health insurance number. And the difference here is that the biometrics will not be taken until after the child has reached the age of 7 years. Again, this is because it recognizes that the regulations recognize that the fingerprints, especially of a child, will not be quite fixed until at least the age of 7. So the biometrics, will be most useful if they're taken after the age of 7 years. Once the child reaches the age of 18, they will then need to update their registration details, and they'll now be issued with the social health insurance number as an adult. However, even though they are deemed to be a separate household at that point, they can still continue to benefit under the parent or guardian's cover until the age of 21. So up to the age of 21, if they are wholly dependent on that guardian or parent, or they are living with that person. So with that, they're still able to benefit under the parent or guardian's cover. If they're in full-time education, again, they will still be able to benefit under their parent or guardian's cover until the age of 25. However, if they reach 18 and they're able to take care of themselves and they have their own income, then they'll also go through assessment to see how much they should contribute, and they'll start making contributions if they are able. For those who, for the spouse, for those who are married, you'll need to present a copy of the ID of the spouse, as well as proof of marriage. Again, the regulations recognize that not all marriages in Kenya have been registered, so a person will be permitted to bring the marriage certificate or another document such as the affidavit. For another child, it is the adoption order in order to have that child registered. And for a child for whom the content has again, they'll need to present a copy of the will or the deed or the court order that appointed that person as guardian, also, or another document that is recognized under the Children's Act. For persons living with disability, the Act says that these persons will be able to benefit as dependents of a contributor for the rest of their lives if they are living with disability and they're wholly dependent on that person. So for those persons living with disability, they will need to have the ID and the certificate of registration with the National Council of Persons Living with Disability to be registered. I mentioned some of the populations that the government will be paying contributions for. So these include people who are in prison and also children in children's remand or rehabilitation institutions. For such persons, they will need to have the prison admission number for those who are in prison, or for those who are in remand, the remand identification number. For children who are in conflict with the law, they will need the admission number of the children of that child to the children's remand home, or the rehabilitative institution, or the child's birth certificate. Now, one important change that happened in the regulations within the last month is that whereas before it used to say that all NHIF members will register afresh, the regulations were amended, especially Regulation 13, to say that members of NHIF will be transitioned, their data will be transitioned to SHA. And this will be done upon verification of their data with government databases. So if you have received a message in the last maybe 1 week or few days informing you that your data has been transitioned to SHA, doesn't mean that's the process. You're still to go to *147# to go to the website, because there's still a few steps that needed to finish the application process. And in addition, it's important to check that the data that was transferred has accurately reflected your details, including the changes that may have happened in between, like changes of number or phone number, or changes of the number of dependents, or maybe if a spouse needs to be added. So it's not the end of the process that the data was transferred. It's important that we also inform employees who are within our organizations that they need to go back to the application and make sure it's fully complete. If you need to amend the beneficiaries under your cover, maybe to add or remove, then the documents will be fairly similar. If it's to add a new spouse, the ID or proof of marriage. If your spouse has passed away, then it's the death certificate. If you've gone through a divorce, then the divorce decree is what will be, copy of the divorce decree will be required. Again, for children, it will be similar documents, either an adoption order or the birth certificate, or a will, deed, or court order for those where the contributor is the guardian. The beneficiary will be deregistered in only one situation, and that is on the death of that beneficiary. So the Social Health Authority will be notified of the death by the Principal Registrar of Births and Deaths. And the main thing to remember here is that even though a contributor might die, if they had made their contributions in advance for the period, then the family will continue to benefit until the end of that contribution period. So to give an example, if I was making annual contributions as a self-employed person and I had contributed in January for the whole year up to December, and I were to pass away in February, then my family would continue to benefit until December. That is the end of that contribution period. So I've come to now to the contributions because this is a fairly important part of the Social Health Insurance Fund. And it's, I think, why we are here today, to also find out how the contributions will be done and how we register the employees under our organizations for the deduction and the remitting of contributions. So the contributions for those who are in salaried employment is that it will be 2.75% of their gross income. So the gross income paid monthly, and it must be paid by the 9th of each month. For those households who are non-salaried, that is the ones I mentioned, who are in business, either sole proprietors or they're running their own, they have their own source of income outside of employment, including farmers, they will be paying 2.75% as well. However, they'll be paying annually. So it must be paid within 14 days before the lapse of the annual contribution period. That means if I paid, if I want to benefit for 2025, then I need to have paid by middle of December this year so that I can now benefit for the whole of next year. For households who are in need of financial assistance, again, this will be done through means testing. The person will be taken through means testing to determine how much they contribute and whether they're able to, require assistance to make the contribution. If it's found that they need assistance, then the national government and county government will be doing that payment within 9 days from the date the annual contribution is due. For those who are in lawful custody, the government again will be paying for them, but it will be doing it annually from the date the annual contribution is due. So I mentioned means testing as how it will be a means of assessing whether households need financial assistance and the household income for purposes of determining the contribution for those who are non-salaried contributors. So it's a means testing tool that has been developed by the Ministry of Health along with the ministry in charge of social protection and the counties. And it uses data that is collected on various socioeconomic indicators of the household. So it's not just one thing that will be determine your income. It's a series of different factors about your household that determine how much you pay or if you need assistance to pay. The key thing is it's not done once. So it will be a periodic process to review the contribution level of the household. So that if, for example, you are running your business and you close down, or if you had a farm and you lost your income from that farm, maybe the harvest failed, has been failing, and you have to lose that farm, then of course, once means testing is done, the next period, you can now be reviewed and you can now be maybe put into financial assistance. Again, if the income of your household has gone up, again, that will require review so that the 2.75% is accurately reflected in your contribution. The final fund, because we've talked of the primary healthcare fund, the social health insurance fund, the final one is the emergency, chronic, and critical illness fund. So there are two groups of people who will be benefiting from this fund. The first is a beneficiary under the social health insurance fund who has depleted their benefits and they have a chronic illness. So that person can continue to benefit under the emergency, chronic, and critical illness fund. The second group of people is those who have an emergency. So here, because the laws of Kenya require that every person must be provided with emergency treatment when they need it, this fund is how that treatment will be paid for. So a person who has an emergency will have access to emergency services, which will be paid for under this fund. The benefits, as I mentioned, the Act says that there are certain benefits that the Social Health Authority must provide, and these have now been set out in detail in the regulations as an attachment. So the benefits are divided into those that are provided under the primary health care, under the social health insurance, and under the emergency treatment. And the benefits are to be every years by a body that is called the Benefits and Tariffs Advisory Panel, which is set up under the regulators. So it's not that the benefits are fixed forever. If you find that the benefits need to be added or to be different benefits need to be introduced, you can actually be making submissions to this Benefits and Tariffs Advisory Panel, and it will be reviewing them every 2 years, including the amounts that are paid for each benefit. So just to run briefly through the benefits under the regulations, because I know my colleague will now go into details about the benefits and how much will be paid under each. But there's the outpatient and the inpatient healthcare services, as well as the maternity and newborn healthcare services. There's also surgical healthcare services, dialysis, radiology. These are the ultrasound, CT scan, and MRI. There's also the mental and behavioral healthcare services and palliative. In addition, there are certain specialized, such as oncology. And for those treatments that are not available in Kenya, the person will be able to get treatment abroad on application and approval by the Social Health Authority. There's also dental and oral healthcare, ophthalmic health services, that is eye care, ear health services, screening, rehabilitative services, assistive devices such as crutches and wheelchairs. Also, mortuary fees will be paid. So the precise amounts that are going to be paid for each benefit have been published in the Kenya Gazette, and that Gazette notice just gives a table that has the scope of the service, that is the type of treatment, the point of access, whether it's a level 2, level 3, or even level 6 facility where you'll be able to get that service, the amounts that will be payable to the facility, and the access conditions. So for example, for outpatient, the beneficiary has to be, once they've done the application, they'll be mapped to a primary healthcare network based on their geographic location. They'll now be able to access the level 2, 3 facilities in that location. Now, sometimes you'll find that the level 2, 3 facility may not be the most easily accessible facility. So in exceptional circumstances, the Social Health Authority can approve for a level 4 facility to offer these primary healthcare services. So just as we wind up on this brief presentation on the Act and regulations, there's pre-authorization for some specialized services under the regulations. Now, what is different here is that under the law, the Social Health Authority must review and make a decision about pre-authorization of those services within 72 hours. So it can only take a maximum of 72 hours to do pre-authorization, so that we don't have situations where people are waiting an excessive amount of time for the pre-authorization requests. It will be done by the Claims Management Office, which will also be conducting peer reviews when considering the pre-authorization. Again, for treatment outside of Kenya, the beneficiary will have to ensure that the contributions to the Social Health Insurance Fund are up to date, that the treatment is not available in Kenya, and it will be provided by a healthcare provider that is contracted by the authority. And it will be done after the authority has approved the same. That I've finished my presentation. Again, this was just a brief summary of what is in the regulations and the Act and how it will guide us for this session today. But if there are any questions or gaps that people feel, members feel that I haven't covered, you can also ask it in the plenary that will be done later in the question and answer session. Thank you very much for listening to me. I now hand it over to you, Mr. Omoga, for the next session.
Thank you very much, Mr. Nyarango, for that very elaborate presentation. Participants, note the areas where you have questions. We'll give you an opportunity at the end of the presentations so that you can ask your questions. The next presenter is Mr. Otieno, who will do a presentation on the SHA benefits package. Mr. Otieno, you can go ahead.
Thank you, Mr. Ngogo. I hope my screen is visible.
Yes, your screen is visible.
Thank you. So I'll take you through the benefit package, and I'll be picking up from where she has left. Just more focusing on the benefit package as a whole and demystifying some myths about the benefit package. So generally, I'll just start by giving an overview. We know initially under NHIF, it was running more of two benefit packages. So there was the national scheme, which used to be called the Super Cover or the UHC. And then we also had managed schemes. So the managed schemes used to be the civil servant scheme, the police scheme, some county government schemes, or DPP and the like. So there's this issue about some people saying the national scheme cover didn't have other services as the managed schemes, and the difference just being that for the other managed schemes like the civil servant schemes, the civil servants were being deducted their medical allowance, and then the government was also topping up some amount for them to be able to get up more benefits under NHIF. So it was more of a managed scheme as opposed to the UHC. So what the Act now is doing is ensuring there's a standardized benefit package for all. So it means the same benefit package is applicable to everyone, whether you contribute 100,000 or you contribute 1,000 per year, then that is what you're entitled to. The second thing is that NHIF was offering two types of contracts. So we had a comprehensive contract, and then we had non-comprehensive hospitals. So what used to happen, a good example is like for maternity, if you went to a comprehensive facility, let's say the government hospitals and most missions, and then some private hospitals who signed the comprehensive contract, then we're able to give you the maternity package of 10,000 for normal delivery and then 30,000 for CS. If you went to another facility that is non-comprehensive, let's say Aga Khan, Karen Hospital and the like, we're only paying a rebate for those particular beneficiaries. So you are only ended up being paid for maybe 3,000 a night, as opposed to getting the entire package. And the same applied for surgery. So you find someone has got an accident, and then you're going to a private hospital, which is non-comprehensive, and then NHIF only pays rebate. And yet if you went to a faith-based or a government facility, we would have been able to clear the whole bill. So now the tariffs are also going to be per household and per individual. So if the tariff for, let's say, an ORIF, which is the fixing of nails for a person who has got a fracture, if the tariff is 150, it means whether you go to Aga Khan, whether you go to Kenyatta National Hospital or you go to Tenwek Hospital, the rate that you are going to be reimbursed is the same across the board. So that is more of the standardization of the benefit package. So I think from there now I can move into the benefit package. Ati mentioned about the Health Benefits Advisory Panel. So that is the panel that is supposed to be providing advice in terms of the benefits that are supposed to be provided. So that panel has not yet been gazetted, but still the Ministry of Health, through the CS, appointed a team that worked on the benefit package. I was part of that team. So generally what was being done is you identify all the possible services that can be covered. So at this point, you include almost everything. So you're just looking at benefits that are accessible to Kenyans within the scope of the hospitals we have. Kindly mute. Once you have the entire benefit package, then you cost it and see the average cost. And then you also look at the population in need, because for every benefit, there's always a population that needs that particular benefit. And I'll give an example of let's say, delivery, because we have around 1.2 million deliveries every year currently. So when you're costing for deliveries, you have to look at and ask yourself, from the data we have, how many of those 1.2 deliveries were normal deliveries, and how many of those delivery were cesarean sections. So from there, you can be able to estimate how much you will need for the delivery package. Then you go for something else like cancer. Then you look at the incidence of cancer in the country. So how many cases of breast cancer do we have? And then you go as far as looking at the different types of breast cancers and how much it will cost to manage each of them. So once you have the incidence in terms of how many people get infected, and then you factor in that, plus the possibility of the increase in incidence, because there's a percentage of increase in incidence for per disease burden every year. So you look at all that, and then after that, after having the population in need plus the cost of the benefit, you'll be able to estimate the budget impact that you will need to cover, like how much will you need to cover the entire population for the entire range of diseases that affect Kenyans within the country. So that budget impact is what now informs how much you need. And then you also next look at how much you have. So there's the aspect of how much you need versus how much you have. Initially, when we were starting the process, the budget was starting at around 700 billion. So that is what you need to fully cover everyone comprehensively within the country for their entire health needs. And we all know with the situation in the country right now, the government cannot afford that. So then now you move into the yield. The yield is now what is available. We had a benefit package that we had presented earlier, and that had a budget of around 107 billion for emergency and chronic illness, and then around 61 billion for primary healthcare, those who are going to be coming from the government, and then around 166 billion for SHIF. That was going to be the contribution from people. But now with the challenges that we had with the finance bill, it meant the government wasn't able to sustain what they were supposed to pay for. So we ended up with 2 billion shillings for emergency and chronic illness, and then around 4.1 billion for primary healthcare. So that meant that we had to optimize the benefit package to fit the amount of money we have. Because there is no need of having a benefit package that is bloated, yet you cannot sustain it. Then you at some point you'll end up not being able to pay hospitals, and then we hit another crisis. So after optimization, then now the benefit package was validated and then now was ready for rollout. And that is what is currently being rolled out. And just to mention at that point, every stage of those negotiations, stakeholders were involved just to see and ensure that we were doing something that Kenyans would be acceptable to them. I'll move into the fund. So actually, I'd mentioned we have the 3 funds. Just to mention that for the primary and the emergency and critical illness fund are government funded. And then the social health insurance fund is now where individuals contribute. So for primary healthcare fund, in terms of access, you just need to be a registered member to be able to access the primary healthcare fund. For social health insurance fund, you have to be registered and paid up for you to access the fund. And then when we look at emergency and chronic illness, you divide it into 2, because for emergency and ambulance, you'll be able to get the service irrespective of you being registered or not. So as long as you are Kenyan, you walk into a facility or you're driven into a facility when you have an emergency, you're able to get service irrespective of your registration status. But now when it comes to chronic illness and critical illness, these are benefits that are supposed to kick in once you exhaust your SHIF benefits. So for this case, then for emergency and for chronic and critical illness, then you need to have been registered and paid up for you to access those benefits. So for primary healthcare, the benefits under it are outpatient, inpatient, screening, and optical services. So these are services that the government will offer just by you registering without even you having to be paid up. You'll be able to get these services. For outpatient, the scope of cover is management of acute and chronic conditions, consultations, lab investigations, imaging, and then we also have prescription medication, vaccinations, outpatient procedures, and then management of mental health conditions, and then all antenatal care and postnatal care services will be accessed to the primary health care benefit package. The proposal for payment is a capitation rate of 900 per person per annum. And this is one of the things I wanted to explain because there's a lot of misinformation about it. Some people are assuming the 900 shillings is what you're going to use to get service. But what is happening is when we look at the entire population, the government, SHA is going to pay this money upfront or after visiting the service, irrespective of whether you go for service or not. So what is happening is, for example, we have 50 million Kenyans, like who register plus their beneficiaries, we get to 450 million. What it means is per year, the government is going to pay 50 million times 900. That's around 45 billion Kenyan shillings. And this money is going to be allocated within the PCNs. So as you register, you are allocated to a PCN. So when you're allocated to this PCN, it means you can access any hospital within the PCN that you see within the list that is there when you're doing your registration. Of course, the list will be subject to change. So you're able to visit the website and see which facilities are within the PCN at every given point. So you are free to go and access services in any of these hospitals. Then once we hit the end of the month, then now we are going to allocate this money to the facilities based on the number of people they have seen and then the type of conditions they have seen, because we also realize different conditions require more inputs. So the management of pneumonia, for example, is different from the management of malaria. So this is what is going to be looked at, but the money is already allocated within the PCN. So they're just going to divide the money based on the number of people they have seen and based on the number of people that, the type of conditions that have been seen within the PCN. So in terms of allocation, these members are going to choose where to go in level 2 and 3 facilities. But the authority is also aware that there are areas where you find there's no level 2 or 3 facility around that place. And then at that time, maybe you find there is a level 4 mission hospital in that area. Because you realize mission hospitals normally come to fill the gap where there's a challenge most of the time. So you find there's a mission hospital in a very remote area, and then at the same time, there's no level 2 or 3 facility. So in such cases, these level 4s are going to be considered to offer outpatient, because the main aim of primary healthcare is to ensure there's access, and then there's also access to medicines and other products. So that is what is going to be done. When you look at optical is going to be offered for those below 18 years as a start, with a limit of 1,000 per household. And then it's going to cover health education, eye tests, and then treatment for refractive errors through eyeglasses. And this is going to be accessed in level 2 to 4 facilities. When you look at the inpatient services, the scope for inpatient service is more of the same across the board. So the same under primary healthcare and the same for level 4, 5, 6. The only difference is for every level, the higher you go, the expanded the services you get. And that is why you'll see the rebates, as we go higher, the rebates are more. So for inpatient, it will cover management of diseases while admitted, consultation, bed charges, nursing charges, lab services, radiology examinations, drugs and post-discharge medication, physiotherapy, and then also administration of blood and blood products. That means if you require a blood transfusion, then it's also covered under this particular package. For level 3, the reimbursement rate is 2,240 per night of admission, with a limit of 180 days admission per year per household. And then we have screening services. Because of the budget constraints, there are services that we have proposed to start within the second year of the benefit package, or as soon as the funds are available. But we're presenting them because they are the entitlements and they will come, and then the costing and award of benefits have already been done. So screening is one of those benefits that we propose to start in the second year. And the screening for a start will target the 4 cancers with the highest incidence in the country, and that is breast, prostate, colon, and cervical cancers. And then I'll move into the social health insurance fund, and this is where the main benefits are. As a summary, outpatient care services, inpatient care, maternity and neonatal and child health services. We have renal care therapies, mental wellness, surgical services, oncology, medical imaging, and other diagnostics, and then overseas treatment. Outpatient under SHIF will be more different than the one for primary healthcare. So the primary healthcare benefit package for outpatient is meant for you to access the basic care, the entire scope. For SHIF, for now, it's only going to cover lab tests for 4 priority conditions. That is diabetes, hypertension, sickle cell, and then COPD or asthma. So this is going to help us build a disease registry. As we know, the system is going to be intelligent enough, and that's why we want to know by the end of the first year, we need to know how many patients who suffer from hypertension are within the country, how many diabetic patients we have, so that we can have better planning in terms of allocating benefits in the second year. So for diabetes, the proposal is to cover lab tests up to a limit of 4,300, and then hypertension up to 2,850 per year per beneficiary, and then sickle cell 6,800, and then COPD stroke asthma at 700. So the limit is once per person per year for this particular benefit package. In patient, the scope is the same as the one under primary healthcare. The PM rate higher. For level 4, 3,360 per night. For level 5, 3,920 per night. And then for level 6s, 4,480. The limit is still 180 days per household per year. Then we have maternity. Maternity for this case, I mentioned ANC and postnatal care will be covered under level 2, 3, and select level 4s. And then normal delivery, cesarean sections, postnatal care, including immunizations of the newborn, postnatal family planning, management of postpartum infections, and then management of neonatal complications, and then also provision of anti-D-serum for next stressors negative mothers will be the scope of cover for this. So normal delivery will be reimbursed at 10,000 shillings per delivery, and then cesarean sections will be reimbursed at 30,000 shillings per delivery. And then the access rules, it will be accessed across level 2 to 6 facility. So for delivery, a beneficiary will choose where they're going to deliver. If you want to go deliver in a level 2, it's okay. If you want to go and deliver in a level 6, it's okay. But for NC and PNC services, then you have to access them in level 2 and 3 or select level 4 facilities. It's divided into two. We have the dialysis aspect, and then we have the transplant aspect, which has been introduced. So it will cover for dialysis, it will cover for consultations, temporary catheter insertion and removal. And then we have lab investigations, nursing care, dialysis services, medication, dialysis, and other dialysis protocols. So we normally have hemodialysis, and then there's hemodialization that is being introduced within the country. So for that, for those, both of them will reimburse at 10,650. This is an improvement from what NHIF used to reimburse, which is 9,500. And that was comprehensive even for the higher hospitals, maximum 2 sessions a week. And then peritoneal dialysis, 85,200 per month. And then for, in case there's top-up requirements, then the member will top up for peritoneal dialysis. For transplant, the package will cover for transplant evaluation, the kidney transplant itself, and then post-transplant renal replacement therapy. So pre-transplant evaluation, this is for the recipient. It will have a limit of 150,000 per household. And then the recipient surgery, the transplant itself, will be reimbursed at 700,000. And then donor nephrectomy will be reimbursed at 168,000. And then post-renal replacement therapy, this is normally to ensure there is no rejection of the organ, and then also to ensure there is well maintenance of the transplant package. So this one will be reimbursed at 200,000 per household. Then we move to mental health and mental wellness. So this one will cover for mental health education, counseling and psychosocial support, screening, behavioral disorders, neurodevelopmental disorders, neurodegenerative disorders, and also rehabilitation for substance-related and addictive disorders. So for outpatient services for mental wellness, they'll be covered under the outpatient package, that is within the PCN. And then inpatient services will also be reimbursed within the per diem rates that I mentioned under the inpatient service. For rehabilitation for drugs and substance abuse, this will be reimbursed at 67,200. In case a top-up is required, depending on where the member accesses service, then that top-up will be able to be allowed from the member. The limit will still be 180 days per household per year, and the access will be across level 2 to 6 facilities. So basically all levels of hospitals. Surgical services, this will cover for admission and then access to either minor, major, or specialized surgical procedures. It will also include management of complications, post-procedure pain management, physiotherapy, critical care services related to the surgical procedure. What this means is we know the surgical procedures, especially the specialized surgeries, like the open heart and the like, or the cath lab procedures. Normally, once you come out of that surgery, you need ICU care. So for these particular surgeries, the ICU care within them has been costed within the package. And once you go through the surgical listing in the Gazette notice, you'll realize that some surgeries are even covered up to a maximum of $1 million. So the provider payment mechanism is on a fee for service. What this means is we have a surgical listing of around 549 surgeries, and each surgery has a tariff attached to it. So this will be the reimbursement for every surgery. In terms of access rules, we'll cover 3 minor procedures per household per year, and then 2 major procedures per household per year, and then 1 specialized procedure per household per year. Hematology and oncology services. This one will cover for chemotherapy, radiation therapy, hormonal therapy, and immunotherapy. It will also cover for lab investigations, and then apheretic platelets and red cell exchange. This is for sickle cell patients. And then radiological services, surgical interventions, and management of precancerous lesions. So we'll have a limit of 400,000. This is for diagnosis, staging, and treatment. And then there's a guideline that is being provided through the National Cancer Control Program under the Ministry of Health and then the National Cancer Institute. It includes how the top priority cancers are going to be reimbursed and managed. So, for example, you'll find a breast cancer, that guideline has what tests should be done, and then what drugs should be used for that particular cancer. So this is going to be integrated within the system that we have. And what that means is all the patients who are going to be managed within the country are going to be managed within these particular guidelines. In medical imaging, NHIF used to cover MRI and CT scan across all healthcare providers with a limited scope. And then it used to cover CT angiogram, mammography, fluoroscopy, echocardiograms, EEG, and specialized ultrasound as a pilot in government level 5 and 6 facilities. So what is being offered now is these particular images across the board in both private and government at a rate of MRI at 11,000, CT scans at 6,900, CT angiogram at 8,000, specialized ultrasound, these are Dopplers at 5,000 shillings, EEGs at 8,000 for a child and 5,000 for an adult. The reason why EEGs for a child is reimbursed higher is because most of these children need to be sedated. So the EEG is normally done under sedation for children. And then mammography at 3,000, fluoroscopy at 4,000, and then echocardiograms at 3,500. The limit has been increased to 2 per household per annum. And then the offer will be in terms of which facilities can be able to offer that particular service. Oral health, this is another service that is proposed to start in the second year of the benefit package at a limit of 2,000 per household per year. And it will cover for oral health education and counseling, screening and consultation, tooth extractions, fillings, and then dry socket debridement, suturing under local anesthesia. And then we also have scaling and polishing plus wound cleaning. And then overseas treatment. The Act now directs that SHA will only offer overseas services to hospitals that have been empaneled and contracted. So what that means, because NHIF only used to offer guarantees of payment, and then you're able to go and to a facility and then they used to pay. So now because the Act stipulates this, what it means is this package can only be rolled out once the contracting has been done. So that process is due to start. And that is why this package will be rolled out within 6 to 12 months after the implementation of the benefit package. So this is to allow for the empanelment and contracting. The limit will be 500,000 per person per year. And then in terms of access, it will only be for services and both medical and surgical that are not available within the country. So that summarizes the benefit package. I'll move into the emergency chronic and critical illness fund. And this is government funded, as I mentioned earlier. For this, we'll have ambulance evacuation services, accident and emergency, chronic illness services, assistive devices, critical illness service, and then palliative care. So for ambulance and emergency, I think that was floated. So it was more of competitive process and bidding. So that is currently being onboarded. And then it will be managed through a national call center. So this is to ensure there is efficiency in terms of efficiency and standard operating mechanisms and of the ambulance service. So it will be accessible to all Kenyans, whether you are registered or not. I had mentioned that earlier. So what will it cover? We have evacuation from the point of the incident to the nearest facility with an accident and emergency center. And then we have the transfer of patients requiring emergency and further clinical care from one facility to another. So I think that is clear. Caroline, kindly mute. And then for accident and emergency, the scope will include cardiac and pulmonary arrest management. We have major traumas, shock states, altered levels of consciousness, convulsions, chest pains, cases of stroke. And then it will also include anti-snake venom and anti-rabies provision. In terms of access, because emergencies don't choose where you get them, it will be accessed across level 2 to 6 facilities. The reimbursement will be on a fee-for-service basis. So I had mentioned it will be covered whether you are registered or not. The only challenge is the emergency service will only be able to cover you within the first 24 hours. After which now the shift benefit package is expected to kick in. And this is one of the reasons why people are being encouraged to ensure they are fully registered with shift and paid up, because the other services are limited. So for example, if you require a procedure, and then 24 hours have already elapsed, and then you require this procedure that is covered under SHIF, then now you might be in a very hard situation. And that is why if you register and pay up, then now you're able to get the entire scope of services from primary healthcare, SHIF, and then now from the emergency chronic and critical illness fund. Illness, initially we had raised for this one, but now because of the budget constraints, we had to shelve that for a while. So currently they'll be covered within the per diem rates, and then the limit will still be same as the inpatient, that is 180 days per household per year. Access point will be in level 4 to 6 because these ones include ICU, HDU, and severe burns unit. These are only available in level 4 to 6 facilities. And then it will cater for critical care admissions in critical care units. So that is, as mentioned, ICU, HDU, and then severe burns, and any other service that will be required. Palliative care, this is a new service that has been introduced and will be accessed across level 3 to 6 facilities. So this is a benefit that aims to enhance the quality of life of patients with serious chronic or life-threatening illnesses, and it will include pain management, especially those who suffer from terminal illnesses like cancer. They normally experience a lot of pain. So pain management, symptom management, psychosocial support, caregiver support, and end-of-life care. So it will also be reimbursed within the normal per diem rates, and the limits will be 180 days per household per year. We have assistive devices. This is another package that is also proposed to start within the second year of the benefit package. And then it will also be offered in level 4 to 6 facilities. So hearing aids will be reimbursed at 55,000. And this is only to individuals aged below 18 years. And it will be once a lifetime, once issued, once it will never be issued again to those individuals. And then crutches at 900 shillings. We have clubfoot braces, and then also therapeutic footwear at 1,000. So walking frames at 500 and foot brace at 1,000 shillings. So that's the end of the benefit package. For each and every benefit package, there are always exclusions, what is not covered, because as you are aware, medical needs and medical benefits are unlimited. So you must have some exclusions at some point. So the exclusions for this case will be cosmetic procedures, unless those ones specified in the surgical listing. So we have cases where we have considered them for inclusion in the benefit package, especially the surgical list. And this is especially for reconstructive surgeries that are sometimes considered cosmetic. But we know, for example, if someone gets a severe accident that leads to a deformation of the face, then a plastic surgeon will have to be involved to reconstruct this face. So in such cases, then those ones will be within the surgical list and those ones are covered. We also don't cater for treatment by herbalists and chiropractors. And then as IVF is not going to be covered for now. We're not saying it's not necessary. We're just saying we can't afford it currently. So if and when the funds are available, then this will be considered for inclusion in the benefit package. And then for now, only the vaccines within the KP vaccine will be covered. So the baby-friendly vaccines are not going to be covered under SHA. And then management of patients within the country are normally guided by what we call an essentials medicines list, and then an essential diagnostic list, that is for tests. So this is provided through the Ministry of Health. So we are only going to cover products within these particular lists. And the good thing is these lists have been updated and they are current as we speak. So we are also not going to cover weight management drugs, and then medical costs related to or incurred in a research environment or clinical trials. Mostly during research environments and clinical trials, you find these people who participate in this are normally covered under another insurance, because you're not likely to do a clinical trial without covering the people who you're going to be used as subjects. And then epidemics and pandemics are not covered because this is more so normally covered under the Ministry of Health through the Public Health State Department. And then professional fees for medical personnel over and above the prescribed rates. And then expenses related to diagnostic equipment, but not limited to, such as glucometer or glucose machine. And then, of course, any other procedure or intervention not listed in the scope of the benefit package. My last slide will be on the vertical programs. And these are programs that are normally donor funded. So ARVs, antimalarials, anti-TBs, and associated tests, plus commodities and KP vaccines will continue to be provided at public health facilities and private facilities. plus faith-based that report to the health information system. Thank you. That's the end of my presentation.
Thank you very much, Mr. Chino, for that elaborate presentation. Participants, as I indicated earlier, just note your questions. After the next presentation, we'll now open the floor for you to ask questions. We're also taking note of the questions you're asking in the chat box, and they'll also be responded to. So we'll get into another session where we'll be introduced to the employer portal. Now, this is very critical to the HR practitioners, and that is why you've been invited to this sensitization, so that you understand how you register your organization and your members of staff. So Mr. Osoro will take us through this presentation. And I can see he's already ready, so you're welcome. Go ahead, Mr. Osoro.
Thank you, Mr. Ngodo. For this matter, my name is Gilbert Osoro. I will take you through the employer portal, whereby you will be required to submit the monthly payroll byproduct for the people under your company. As you can see, I'll do a brief introduction before we go to the technical bits. Now, the Social Health Authority, which is a new entity that provides comprehensive health insurance system, has established a portal to
Mr.
ensure
Osoro,
that...
Mr. Osoro, your voice is not very clear.
All right.
It's a bit of an echo.
Okay.
I don't know, check what's the challenge.
Okay, can you hear me now?
A little bit echo.
I'll try to see where the echo is coming from. We normally have a bit of a challenge here, but I'll try to get the best position. So allow me to proceed.
Okay, just proceed.
Can see, thank you, Mr. Ngodo. The purpose of this employer portal is to enhance service delivery and simplify the registration process for various groups, including individuals, families, and business. The page you are seeing is the landing page when you log into the SHA portal. And the first thing, it will ask of you either to log in or register fresh. Now we'll go to step one, which is registration. Under registration, there are three avenues one can be able to register with SHA.
Yes.
The first avenue being NHIF employers. Employers previously registered under NHIF are automatically migrated to the SHA portal and only require to update the information on the SHA digital platform for purposes of continuity of services. Number two, you can be able to also update your details through the National Social Security Fund, NSSF, whereby employers registered under SHA can use the NSSF credentials, because the government has put effort to integrate social security and healthcare services and link them up to the new SHA portal. We have introduced two more additional features. One is for domestic employers, and for purposes of domestic employers, SHA has introduced a simplified registration process, allowing employers to register their domestic staff for health coverage. The process is designed to ensure that workers in the informal sector who may have been underserved by the DEF and NHIF can receive comprehensive health coverage. Last but not the least, for the new businesses, that is newly established businesses, they are required to register the employees with SHA as part of their compliance with the national regulations. And to access this SHA portal, you need to type the URL and of course you write employers.sha.go.ae. I think I've mentioned on the four avenues of activation to the SHA portal. The first one being activate with the NHIF services, activate with NSSF e-services, new employer, and a domestic employer. Allow me now to take a deep dive on how to activate with NHIF e-services, or what is known as the monthly payroll byproduct. I'm sure many of the HR practitioners that are on board today are aware that under the defunct NHIF, they used to submit monthly payroll returns, and it was required of them to log in using the employer code. Number two, the registered email address, and finally, the monthly payroll byproduct password. Now, when you come to this particular page, whereby you want to activate using the NHIF e-services, you will be required to complete the 3 mandatory fields, being number 1, employer code or number, number 2, employer email, number 3, e-service password, and you proceed to submit. When you submit, upon successful verification, the employer will be directed to this page you are seeing currently on the screen, and the employer will be required to update their records with SHA by filling the required fields and attaching some documents to support your application. Now, this is the verification page. Now, there are some mandatory fields that you need to complete. Number 1 being the contact name of the person, the physical address. You need to indicate the Kenya Revenue Authority PIN number. You need to attach or indicate the business registration certificate. Of particular note, there are some fields that will auto-populate. 1, the organization name, the contact phone number, amongst others, and postal address will auto-populate. Now, of particular importance in this particular screen, remember your verification is to the new social health insurance. So we need to get the administrator's details, who will be in charge of this particular process. We need the first name, last name, the phone number, official phone number where you can be reached, the office phone, the official email address, and finally, you need to reconfirm that particular email address before you proceed and submit. Upon successful submission, it will take you to the other page. This also applies for those employers who need to activate with the NSSF e-services, whereby they need to indicate the employer number, the NSSF employer number, the e-service username, and finally, the e-service password. And the same procedure will be replicated, just like we've done for NHIF verification, same case with NSSF. Allow me to speak briefly to people who are starting new businesses. And to register the new business in the SHA employer portal, the user will complete the form that is displayed on your screen. And among the mandatory requirements, you must complete the organization name, you must enter the contact person, you must indicate the contact phone number, the physical address, that is the location, the postal address. You need to indicate the KRA PIN, and it's a requirement. You upload 2 key documents. Number 1, the single business permit or certificate of registration, and finally, the KRA PIN, which must be uploaded in form of a JPEG image. It could be PDF, PNP, or many others. But of key interest is the admin details. These are mandatory requirements, whereby you indicate the first name, last name, the phone number of the admin, the official email address, and which needs to be reconfirmed before you submit. Now, for the new domestic employer, to register a new domestic employer on the SHA portal, one must complete the form below. And of course, you have to click domestic employer. You have to provide the employer details, the first name, middle name, last name, the national ID number, the KRA PIN number, the official phone number, the email address, and you have to confirm that email address before you proceed and submit. Allow me to take the team through the password setup. Upon successful verification, the employer will receive an email to allow them set the password. And password setup instructions are shared to the official email that you provided upon verification, as shown below. One of the things you need to take note of, to reset your password, which will be sent to your email, you'll also get a one-time password to enable you login. I want to display to you what you'll receive in your official email address. Once you open that particular email address, it will welcome you to the Social Health Authority. You can see for this case, we have Dylan, and he's been welcomed to the SHA portal. It will require you to set your password. At SHA, we realize that it's important to secure your login credentials. To that effect, you will be required to set your password that you will use when you are logging into the SHA portal. Now, the user will be required to complete the following mandatory fields, and this will be the credentials to be used in conservative login. Email address that you used, the official one, the password, and for this particular matter, for purposes of confirmation, you need to confirm the password before you proceed again to submit. That is for purposes of setting the password. Once that is done, you will go back now to the SHA portal and log in. After successful password creation, the user will be required to use the credentials that you set up to log into the portal. And as you can see there, login into the account to the Social Health Authority, you will indicate the email address, and finally, you indicate the password. Then you click the blue at the bottom of the page, which is login, to allow you log into the portal. Now, the user will be required to enter the credential and a 5-digit one-time password for the two-step verification of the user as shown below. Of particular note, we have a two-step verification to enhance security for purposes of accessing data into the SHA portal. So the one-time password or code will be sent to the registered email address and the phone number that you registered. Once you enter the 5-digit password, you proceed to the next stage. As you can see, I've shared a sample SMS one-time password, and it is written that your one-time code is 19754 Social Health Authority. Please proceed to consume this to allow you to log into the portal. You can see the sample one-time sample mail of the one-time password that will welcome you and indicates the mail. Now, upon successful login, it will take you to the dashboard, what we call the landing page or overview. Now, that landing page is where the rubber meets the road. You can be able to see a number of things. The first one, you will see your profile, whereby we have your name. There is something written SHA ID that is system generated. You can go to home, and we are currently at home. We have another drop down on the organization. This is where the rubber meets the road, because the payroll data is processed in this particular portal. Now, for purposes of the meeting, there is a prescribed format for submitting data. And I want to implore the participants that you can see something down there written, download payroll templates. Please proceed to click download and proceed to complete all the fields that are in that Excel sheet, which I'll be showing next. The other thing I want you to take note of is once you successfully download and complete the Excel file, it is a requirement to upload. You can see it is written number 1, upload file. Choose the particular file. Once you choose it, proceed to upload. Now, I note there is a second thing written down there as the add employee. In event you submit your byproduct, let's say for the month of October, you realize that you forgot to add some 2 people. What you do, instead of re-uploading or trying to overwrite, this SHA portal is user-friendly. You can proceed and add the 2 employees, and you'll add them manually, including their full names, ID numbers, KRA PIN, cell phone, and many others, as you'll see down there. This portal is very interactive. It can give you an overview of the submissions, the number of employees, the number of previous submissions that you've done. It will keep a track record. It will show you the number of e-slips, and it will give you the e-slip number. And finally, it will give you the transaction history. When you talk of overview, it will tell you about the total payments, the number of employees you are remitting for, and number of submissions. And this system has an AI capability. In event you do not submit in the prescribed format, it will tell you by highlighting in red that the submission has been rejected, and it will go further, indicate why it has been rejected. Now, allow me to take you to downloading the payroll templates, and you can be able to see once you click the download payroll templates, you'll be able to get the Excel sheet that is in the following page. I want to share with you the Excel sheet, and I want to make particular focus to the mandatory fields. You need to indicate the payroll number. I know each employer has a unique payroll number that identifies the employees. Indicate the first name, the last name, the national ID number, the Kenya Revenue Authority PIN number. Indicate the this particular upload as an issue. We don't have that column called gross salary. This was done earlier on, but we have the contribution amount. Indicate the contribution amount. And I want to emphasize that the contribution amount is equivalent to 2.75% of the gross salary. I repeat, contribution amount is equivalent to 2.75% of the gross salary. Finally, it's imperative to indicate the cell phone number for the particular employee. And I want to use this opportunity to tell people there are 2 things I've noted. Some employees have ID numbers that start with a 0. And when you populate 0 in the Excel sheet, without turning it into text, the 0 disappears. And it's a common problem when we have phone numbers and ID numbers that start with a 0. So ensure you turn it into text through Excel. And it's a requirement. You try to you complete all those fields for you to have a successful submission. Allow me to speak to the second issue that I said, whereby you have already submitted your main payroll, and you note that some 2-3 employees were erroneously omitted. You click that add employee. You can see it's number 2 there, add employee. Now, when you click add employee manually, the following fields are required to be completed: the payroll number, not NSSF, but the NHIF number. You need to capture the surname, other names, the national ID number. Remove that gross pay. You need to capture the monthly contribution, which is equivalent to 2.75%. KRA PIN, which is also not mandatory. And you need to save the member to update the data. This is the field that we are seeing where you add the employee. You can see all those things that I've mentioned, including the KRA PIN, the ID number, the surname, last name, and payroll number. Now, of particular importance is creating the submission. Now, the user selects the submission month. For this case, you will be making submission for the month of October 2024. Proceed to click the submit button, but before you do that, confirm you selected the correct submission period. Thereafter, proceed to submit. What the system does, it is intelligent. It will give you a summary of what you have successfully submitted. It will indicate the payroll numbers, for example, the employee name. Please mute. It will give you the employee name, the national ID number, the cell phone number. There is a system-generated CR number, which is the clear industry number that will be populated by the system. The SHA ID.
Otoro, kindly unmute yourself.
Osoro, kindly repeat step 7 before we go to 8. There was a lot of noise.
And then unmute yourself, Osoro. You are muted.
Sorry, I was muted without knowing. So we are now at my organization. Under my organization, the user can view the organization details. Alternatively, they can add other users apart from their admin to the system. And when you look at the organization, you can be able to edit the organization name, add the KRA PIN. You can also add the official contact email address, the official contact phone, the physical location, the postal address, and you can see down there, we have a summary of the users. In this case, there are 3 users. The beauty with this, you can be able to add users. On the extreme right, you can click that add user button, and it will require you to complete the following mandatory fields: the full name of the user you are adding, the official email address he's using, the cell phone, the phone number. It has what we call a time log, the last login, the status, and the day this user account was created, and whether it's active or not. So this is the add users portal that I've just shared that has the following mandatory field: first name, middle name, email address, phone number, and user type. The good thing with this system, it is user-friendly. It recognizes hierarchy of authority. We have the admin, we have guys from finance and operations who can be able to be given user logins based on their job description. Allow me to take you through the password reset. In the unfortunate event you forgot your password credentials, you can click forget password and provide your email address to allow the system send you the password for purposes of regaining access to your account securely. So at the reset password, you will enter the email and proceed to reset. Now, reset password instructions are fed to the user email address, and it's secure. Once you've done so, you need to indicate the address. Now, the following instructions are fed to your email to allow you to reset the password. The user then clicks on the green reset password as shown in the box below, and you'll proceed to reset. And of particular note, the password reset link has a duration within which it expires, and that is 60 minutes. If you do not request a password reset, no further action will be required. Now, when you get the new credentials, you need to enter the new password and you need to confirm it before you proceed. After successful confirmation, the user will be required to enter the one-time password that was sent via the official email or a text message SMS, and it is a 5-digit one-time password which will enter and proceed. That marks the end of my presentation. I'll pause there and hand over to the chair, Mr. Ngodo, for the plenary session. Thank you for listening to me.
Thank you, Mr. Osoro. That was a very nice presentation. So we are participants, we are now coming to the question and answer session. And kindly, I'm requesting those that I have logged in with the link that I shared, kindly log in with your name. There are so many Renard Gothos who have logged in. Log in with your name so that your identity is clear. So we'll now go to the question and answer session. So you raise up your hand if you have a question, and we'll give you an opportunity. And I'll request Dr. Tracy. Dr. Tracy, if you are in, kindly moderate the question and answer. Dr. Tracy, you can hear me? Soro, kindly mute. Dr. Tracy, are you in? Okay, I can still handle the questions. Anyone with a question, raise up your hand. On any of the 3 presentations. Yes. There was a hand from somebody. Is that Mother? Kimodo? Mother, was your hand up?
Good morning.
Okay, continue, Vincent.
I'm Vincent calling from Mombasa Coast General. I was asking about the critical care. Payment mode will be per diem. I was just asking for ICU charges. Does it mean it will include copay? Because from experience, per diem relating to critical care or ICU stay requires, the bills are normally higher. And you cannot compare that per diem for a normal ward and a patient stay in a critical care environment. And 2, under the primary health care fund, where facilities are put in a PCN, we know the issue of capitation works well when we have large numbers. The kind of care that those facilities in levels 2 and 3 will be providing, in case the numbers are not sufficient, or a facility within the network that is getting below average numbers in terms of the patients attended to. Since we've said the reimbursement will depend with the number of patients they've seen, will it be feasible for those facilities? Or how will those facilities get support to ensure that they still remain above, they still put their heads above the water in terms of running costs? Thank you.
Thank you, Vincent. Your question will be answered. I saw a hand from Porin Yamai. Porin, go ahead. Vincent, can you mute?
I have muted.
Okay, lower your hand. Okay, seems like Pauline. Pauline, are you on?
Yes, I'm on. My question was, on the employer portal, step 7 was not okay with me. There was a lot of noise.
Okay, another hand. Gilbert, mute. Gilbert Osorov, can you mute your side?
Yes, I've unmuted. It's muted from my side. Pauline, come again. What particular aspect of the stage you didn't get so that I respond when time comes?
Okay, Pauline, come up again.
Okay, thank you. I was asking about, sorry, about the employer portal. Step 7 was not clear due to some noise that some people were making. Can it be repeated kindly?
All right, I will repeat it.
We've heard you.
We've heard you.
Okay.
Another hand.
Hello.
All right, Hassan.
My name is Hassan. I'm calling from Garissa. The process of registration seems to be a bit tedious. If in case I don't understand, is there an office which I can refer to?
Thank you, Hassan.
Are you hearing me?
Yes, we heard you, Hassan.
Yes.
Another question, the last one, then we respond.
I have a question kindly.
Proceed.
Would SHA kindly consider sending confirmation emails to employers who are successfully registered? Because there's a bit of panic. There was no confirmation message at the point of registration.
Okay, thank you. SHA team, maybe you can take up those questions before we go to another round. So whoever is ready to respond to any, just take the microphone.
Okay, I think I'll start. So there was a question about ICU, whether copay is allowed. Yeah, I started by mentioning we had an initial package which had 107 billion for emergency, critical, and chronic illness. And what happened is because of the budget constraints of the finance bill being put aside, we had to work with 2 billion for emergency and critical and chronic illness. And that is why we are currently going with the rebate for ICU, HDU, and then severe burns unit. So what it means is the rebate will be subject to copay for ICU as it's a new benefit package. And then once we have funds for rollout, then the ICU and HDU benefit package will be fully rolled out. The second question was on PCN. And I'll just mention that as opposed to NHIF, the challenges that were with the NHIF were mainly the main registration was from formal employment. And then for self-employed, there was a lot of adverse selection. Adverse selection meaning most of the people who are registering were registering because either they are sick or they require service. And most of the time, once they are done with the service they required, then they stop paying. So being that now primary healthcare is government funded, and remember I mentioned for primary healthcare, all you need to do is be registered. So as long as you're registered, then you're able to access the service. And then you don't have to be paid up. What that means is just by registration, currently we have 12 million registered members. And with an average dependence of 4, that comes to 40 plus million. So if everyone declares their dependence, already we are talking about almost 40 million beneficiaries. So if you allocate 900 for 40 million beneficiaries, it means you are going to see a lot of efficiency. And even the reason why the government is going the PCN way is to, one, ensure that there are two things. There is the FIF bill that is going to ensure hospitals have enough drugs, the government facilities. Because the challenge we had is you find so many people are willing to access services in government facilities, but because most of them know you'll go there, most of the time you'll see a doctor, and then when a lab test is required, sorry, then you're told maybe this test is not available, you have to go get it somewhere, or when a particular drug is required, you're told there's no drugs. So the FIF bill is going to ensure that all the monies that SHA remit to reimburse to these facilities, they're able to use by themselves. So the money won't be going to this country central account and then now it's disbursed maybe for other budgets or something. So that is going to ensure these hospitals are well equipped and then they have the entire products that they require, both medical and non-clinical. So once this has happened, it means people will be able to access service. And then the aspect of only registering even without being a paid up member, then being able to access this service is also going to help. And then for the PCN, we are not saying we are allocating money based on the number of people you have seen. We are allocating the entire 75 shillings per month per beneficiary, because if you divide 900 by 12, you get 75 times the number of people within that PCN. So this money is going to be available. So the only issue is now, how do you share it at the end of the month? So we are going to share it based on the number of patients you have seen, and then based on the type of conditions you have seen. So it means this money is going to be available for you for the entire PCN. And the PCN is going to decide how they're going to use their money. So for example, you find a facility has seen 20 malaria cases and 10 pneumonia, and then maybe intestinal worms, 5 and something. And then the amount allocated to the PCN might be maybe 1 million, for example. And then you've only utilized 500,000. The PCN now decides whether to share the remaining 500,000 in the same proportion that shared the 500, or now they say, because we have this 500,000 within the PCN, let's use it to do other things within the PCN that will ensure we spend less on treatment. So you can even move into community health initiatives like clearing bushes and all that. So it's a vision that the government wants implemented to ensure afya mashinani. In other words, everyone is able to get service, and knowing that each and every area has unique problems. So we cannot implement, the problem we have had is we are trying to solve unique problems that affect different areas with a universal package. So when we're able to allow each and every PCN to make their own medical decisions, then it's going to help. And remember, the PCN includes both government facility, faith-based, and also private facility. So I think that answers the question that was asked. Thank you.
Should exit this thing. Okay. It might make noise before I know it.
Mute.
Yeah, can I proceed?
Yakrin, mute your end. Yakrin Osoro. Can proceed, Osoro.
Thank you, Chair. I'll answer the 3 questions, starting with step 7, that we were requested to share. Somebody is sharing before me. I'm trying to get, yeah. For the benefit of the team, I'll share stage 7. Now, stage 7 is step 7 rather is titled creating submissions, and the user selects the submission month. For example, at the end of this month, we expect all people making submissions to select the month of October 2024. Once you select the month, it populates, and you proceed to upload the completed monthly payroll by product. And upon successful uploading, it will give you a summary report of what you uploaded, including it will tell you the active employees, the employee's name, the ID number, the phone number. We have something that is auto-populated by the system is called CR number, which in full means client registry number. We have the SHA ID, which will be auto-populated, and the contribution amount, which is equivalent to 2.75% of the gross pay. It will also tell you the status that the member is active, and it has a time log that indicates the last update that was done. I hope it is clear. Allow me to answer the next question that was raised by Violin, who requested that SHA should consider sending confirmation emails. Your point is noted. We will endeavor to create a system whereby upon successful confirmation of registration, you get an email for purposes of assurance. The last bit being the question that was raised by Hassan, who is in Garissa, who said that the registration is tedious and they require a support system. I want to assure Brother Hassan that we have registration and compliance officers in the branches and regions who have been given the task of sensitizing all employers and working with them as they enroll. Thank you. Over to you, Chairman.
Thank you, Mr. Osoro. And I think we've answered all the questions. Anybody whose question was not answered? All right, so we'll proceed to another session or question answer. And this one I will ask Dr. Tracy to handle. Dr. Tracy, take up the mic.
About the mandatory field for attachments, is where institutions are supposed to attach the certificates of registration. What about institutions which do not have a certificate of registration and the field is mandatory? The field is marked mandatory. You must attach something, and the institution which do not have certificate of registrations, like the county assemblies.
Can I respond? Or we pick 4 more questions.
I don't know if you can hear me.
Yes.
Yes, my name is Nathan. Now, I want to inquire on the payroll template, because it has fields for payroll numbers and the other details. Now, for the staff without payroll numbers, is it mandatory that that has to be, because they are staff without payroll numbers, so then that column will be blank. Would that still work? Thank you.
Hello, I have a question.
Catherine.
About the primary health care fund. I see that for you to be, you have to be treated in a level 2 or 3 facility before you proceed to the level 4, 5 or 6. I want to know what are the diseases that I have first to go to the level 2 and 3 before I proceed to level 4, 5 and 6 for referral, because most patients will not understand that before you come maybe to Kiambu level 5, you should have gone maybe to a lower facility. Thank you.
Can we respond to the question so far raised? Dr. Tracy?
Yes, let's respond to those questions before we proceed to take on more.
Well guided. Allow me to respond to the first, I think, 4 that touch on the employer portal. And I'll start with the question that Hassan has raised about the mandatory fields when it comes to registration to SHA, whereby he did indicate that the certificate of registration of the single business permit is one of the mandatory fields. Now, what my understanding that that particular portal is for county governments and national governments. I know you may not have those requisite documents. This one is mandatory to the businesses apart from central government. And it is not mandatory. You can proceed and omit it and proceed to submit. But what I know is mandatory is the KRA PIN. So, Hassan, your fears are allayed. And we are making the portal more user-friendly. In future, we are trying to listen to our members. We say the customer is the king and right. Going ahead, we will provide a place where you just input the number and verify the PDF document later. On the issue that has been raised by Brother Nathan, on the payroll template, staff without payroll numbers. My understanding is that the payroll numbers are not capped in stone. You can proceed and make your own payroll numbers that you feel comfortable with for purposes of counting or recognition in the portal. So if you don't have, you can create 1, 2, 3, 4 and proceed. The issue that was raised by Catherine on PHC on the diseases that are treated in level 2 and 3 facility, I humbly request Joseph, if you are still on board, to respond to that particular question. Thank you.
Okay, thank you, Osoro. So, okay, what the government is trying to achieve is to ensure access to healthcare is highly improved, and at the same time, ensure each and every level of healthcare deal with what they're supposed to deal with. So the patient journey, the reason why I even mentioned there's particular level 4s that will be allowed to see outpatient cases is because of access. So we know the most number of hospitals are level 2s and 3s. So if you are living somewhere, the next hospital to you is likely to be a level 2. So when you get sick, you have a headache, you have cough, you have some chest pain. When you get sick, you don't know the disease you're suffering from. So you go to the nearest health facility for them to be able to know what is happening with you. And if it's something they cannot handle, then they will refer you to the next appropriate facility. So we will not come in and say there are particular diseases that are supposed to be treated in primary healthcare level. No. Because a good example is, even if you talk about malaria, we have normal malaria whereby it's uncomplicated. You can go to the level 2, you get treated, you go home. The same malaria can be severe to a point you're having convulsions. And for that case, you can call for an ambulance and then you can be driven into the next close level 4 hospital where you're going to be managed. So we can't call it in a disease manner, but we can say, whenever you fall sick, then go to the closest health facility. Remember, the government has provided free ambulance service through primary healthcare service. So once you get to the next healthcare facility, they'll be able to offer emergency care, even if required. If emergency care is not required, and it's just a normal case they can manage, then they'll be able to treat you and you go back home. So the message is, we tell Kenyans to access service in the next available level 2 or 3 facility. If the level 4 facility is the closest and it has been contracted by SHA to offer outpatient, then they go to the next level 4 facility, which has been contracted for primary healthcare. And then from there, they'll be guided on what next. If you're going to be managed there and treated well and good, if the facility cannot offer the service available, for example, someone undergets an heart attack and then you go to the next level 2, the system is smart enough to even tell the hospitals will be able to know which is the closest cath lab around you. because it's a cath lab that will require to either remove a clot or something within your blood vessels for you to be able to get help. So at that point, the hospital won't refer you to the next level 2 or 3 or 4. They'll refer you to the next facility with the cath lab available. So I think the message is just for us to tell Kenyans that once you get sick, then go to the next available primary healthcare center, which is either level 2 or 3 within your PCN, and get treated. Thank you.
Thank you very much for those responses. I believe for those who had asked the questions, the answers are adequate. We can take move on and take another round of questions.
Good morning. Hello.
Yes, we can hear you. Go on.
I have two questions. One, I want to ask for the employers who have we registered through the portal as a new employee, yet they are not. How can you be able to migrate the data? Second question is that what constitutes to be a gross salary in determining the deduction? Because there are some leave allowances for the employees. Are we including the leave allowance into it? Kindly clarify that 2 point. Thank you.
Thank you. Question has been noted. Let's take a few more questions before we respond.
Good morning. My name is Meshak. I have a question. I was trying to add employees into the portal for after adding the employer, but when I added, there are some employees who are not being issued with the automatic CR number. So how do I go about that?
We have a big network, and I'm not sure if we have to collaborate.
Thank you. Next question.
I'll go next. You can hear me. Good morning. Thank you. My question is still on the computation.
I don't know whether it's just my side, but I can't hear the...
Yeah, we can't hear her.
It seems we have lost her.
Sorry, I think I got muted. I was asking about the allowances earned by the health professionals when we are computing the gross salary for this SHA. Are we including all that, or we are basing on the house allowance, commuter allowance, and the commuter allowance and the house allowance?
Thank you. So, Mr. Osoro, you could respond to those 3 questions.
Thank you. And thank you for the questions. I'll start with the first question, whereby we had employers that erroneously registered as new employers. What we imply is that if employers were previously registered with the defunct NHIF, and at the point of the registration, instead of activating or updating their services, they keyed in as new employer. Now, we have gotten so many complaints pertaining to that, and I want to report is that the system developer is working overdrive to ensure that they are able to provide a linkage to the employer history that is captured in NHIF database to the new employer code. So it is something that is works in progress. We shall be able to report before end of today or tomorrow on the success of that, and we understand it, but many apologies to the listeners. There's the other issue that has been raised pertaining to the definition of gross salary. And indeed, we have received so many requests pertaining to this. We have written to legal to provide guidance of what constitutes gross salary, but it is a work in progress. Allow me to report, because we'll be issuing a guideline to guide employers. As I'm told, the housing levy, there was a similar thing. So through the chair, I'll humbly request, we put issues of allowances on the back burner as we await for legal to communicate. The understanding we have gross salary are all incomes that are due or paid to an employee, but the other exceptional cases will wait and respond. And to rest it there, the past take further questions.
Yeah, I think you missed out on the
Mr.
question on the CR number.
Oh, CR number, yes. Sorry, it nearly escaped my mind. The CR number is an abbreviation for the client registry number. Now, that CR number is auto-generated by the system upon successful registration or successful submission of a payroll byproduct. So we will wait until when you submit and pay successfully, then the system will proceed and generate the CR number. Thank you.
Thank you very much, Mr. Osoro. I think we can take another round of questions if there are more questions.
I have a question. Thank you so much. So my question is very direct. I just wanted to know, once we upload the employees on the system, do we need to have them register afresh on their own, or this is just enough?
Thank you for that question. Let's take 3 more questions before we respond.
My name is Hassan. I'm still calling you from Garissa. Can you kindly share a link on how to register individual staff and their dependents?
That is noted. Thank
Hello.
you.
Hello.
Yes, you can go on.
Yeah, I really do not understand who I'm supposed to cover. Under NHIF, I used to cover my husband and my child now, who is 19 years. Under SHA, I am employed but my husband runs errands. So that's how I was covering him and my child, who is 19 years now. I understand there is supposed to be household assessment where the children will be over 18 years, they will be assessed, all that. But currently my child is a student. So I'm asking that so that I may understand, under the SHA, am I still covering my husband and my child, who is 19 years, or what is the scenario?
Thank you. We have noted the question. Let's take
a follow-up to that one. I don't know whether I'm the only one, but I've gotten this link for Zoom, this message for this session. Very late. Hello? I have gotten it.
Yes. Okay. It seems we've lost the last bit of the question.
I have a question.
May I ask for clarification kindly?
Please go on.
Okay, on the CR number, after uploading the employees' data, we were told that it's automatically generated. Now, does it mean that we will have to wait till now we will have to wait and submit the October data so that we can be issued with the SHA numbers?
My question was a follow-up of my colleague from Mandera. When
Hello.
we have registered our...
Hello.
I don't know whether I'm still on.
Yes, you are on. Please continue with your question.
Hello.
This is Lillian. When we have registered our dependents, or are we allowed to register our dependents as the employer? And once we have registered, are we required to go back and register individually on our own as employees? Thank you.
Thank you very much for that set of questions. And I believe, Mr. Osoro, you're still the best suited to respond to them. You could respond before we take further questions, please.
Thank you, Chair. I'll start with the employer registration on their own. I wish to confirm that it is the civic duty of every Kenyan to register with the Social Health Authority. And the authority has made it seamless, whereby they can register from the comfort of their phone by dialing the SHA code, which is *147#. The other way they can register is through the web portal by logging into the SHA portal, or in alternate, Afya Yangu. Finally, we have what we refer to assisted enrollment through the community health promoters, and they're in excess of 107,000, and the SHA service points, which are the former NHIF branch offices, whereby you can just walk in and proceed to be assisted to enroll. Hassan asked whether they register both the principal member, who is the contributor, and the dependents. That is, when we talk of dependents, we imply the spouse and children arising out of that marriage. I want to confirm to Hassan that you can do so by, first of all, yes, you can be able to register yourself, and you can also proceed and register your spouse to SHA. Of particular note is that your spouse must be registered to SHA so that you can be able to successfully declare him on the portal. So we have made a provision for that. It is available both in Abiang and the SHA portal. There's a very important question that was raised by our sister, that whom do I cover for? That is, Lina, please mute.
0726 na WhatsApp akaingiangi haraka.
Lina Ayanga, please mute. Thank you. Whom do I cover? Under the SHA, we recognize the nuclear family. And when we are talking about nuclear family, we are talking of the principal member, the declared spouse, and children, be it biological or adopted children, through, of course, the legal procedure. Now, for you, you will be declared as the principal member. You will tell your husband to register also to SHA, so that the system can pick him as a dependent. On the issue of your child, whom you mentioned is 19 years, the Act provides that at the age of 18 years, the child will proceed to the nearest SHA service point and apply to update his application from being a minor to a major. And in you correctly indicated that this child is in school. He doesn't have any income of their own. So as a parent, you will continue paying for him up to the age of 24 years, when he will be treated as a separate household on his own. The other clarification that was sought relates to the TR number that is displayed once you successfully uploaded your monthly payroll byproduct. I did indicate the CR number refers to the client registry number, and it is a number that is automatically generated upon successful submission of the monthly payroll byproduct. You have generated the e-slip, you have paid. For the avoidance of doubt that this number will only be generated once you remit premiums successfully with SHA. I believe I've answered the questions that have been raised. I submit and hand over to the chair. Thank you.
Thank you very much, Mr. Osoro, for those elaborate responses to those questions. I believe they have been satisfactorily answered. Looking at the time, probably we'll take the last round of 3 questions.
Yes, I have a concern. Hello?
Yes, please go on.
Yes, I have a concern. I got this invite of Zoom in our platform. And when we were trying to ask the time, it's like it was not known. So what I'm trying to say is that I've asked colleagues, but when we joined in, it was almost at the tail end. So I'm requesting if we could have I don't know whether it is very realistic, but a repeat of the same, because what from the questions that are being asked, I'm seeing like the discussions have been very healthy and very informative, but we have come in at the tail end. So it's a request that we can have a round of the same Zoom message, please.
Please let us know your name and your organization so that we can know which area or which sector you belong to. I'm asking the person who was on the floor. It would have been good if you told us your name and which organization.
Yes, I'm Mary Ngugi from the State Department of East African Community. I got the invite from the Zoom credential directors platform.
Okay,
Hello?
that is well captured.
Hassan from Garissa County Assembly. Since it is a self-registration and you have insisted on self-registration, could it be possible that one gets a code of a certain institution and register with it that he is a member of that institution?
That
I have a question.
Yes, proceed, please.
I have a question. Sorry, Isaac Boyd. Isaac Boyd is in Mombasa. Is currently the chair of Post Eastern Branch, IHRM. So I have two issues. One is thank you for clarifying that we have regional maybe coordinators who are guiding us in a few things on SHA. I will request that where possible, kindly share with me maybe contact for a regional person here. We can organize also for a forum. Probably it can assist us from here. Then the second thing is I think you're leaving us in a limbo. There's a question that somebody asked about the gross salary. When you're saying you have written to the legal team. Now, my concern is that we are supposed to recover for this October payroll, and when you talk of that you're still waiting for maybe a legal interpretation about I know the law is not explicit on actually what is gross, what it entails in gross, and in that case, we have the payments which comes once in a month, and others are maybe recurring. Other allowances could be recurring. So at the moment, what should I use to make the recovery as we are waiting for the legal interpretation? I think that is a concern that it comes general to every HR person. Then the third thing that I think we also need to factor in is for any person who is the HR professional, I think it is important. Okay, maybe I'm addressing this to HR professional. It is important that when you have your payroll, you have numbers, you have the personnel, or rather, the payroll numbers or personnel numbers, so that it gives you accountability. I had a question maybe from our own HR person where you're saying you don't have personnel numbers, you don't have the employee number. And it is important to have employee number for accountability purposes. I think that is for clarity in our case for those HR here. Kindly share the coordinator for cost, that we will organize also for a forum here, if you are allowed. Thank you.
Thank you very much for raising those concerns. In matters of organization and of future forum for the same, I'm going to hand over the floor to Mr. Ngoto so that he can respond to that and take over the program after that. Thank you. Mr. Ngoto?
Thank you very much, Dr. Tracy. And sorry I didn't introduce you. Dr. Tracy is the head of Health Financing Division at the Ministry of Health. And I also didn't introduce myself. Sorry for that. My name is Leonard Ngoto. I'm the Director, Human Resource Management and Development, Ministry of Health, State Department for Medical Services. So as we come to the end of today's session, I want to thank all the participants. This session was meant for the county government human resource directors, but
we lost you.
Am I being heard? Sorry, I think I muted, unfortunately.
Yes, I can hear you.
Okay, let me do it again. So first of all, I wanted to thank Dr. Tracy. Dr. Tracy is the head of health financing in the Ministry of Health. And my name is Leonard Godo. I'm the Director, Human Resource Management and Development. So this session, we've carried a number of sessions, sensitization session, focusing on HR practitioners because they are the key in implementation or rollout of SHA. So we've done for the ministries, we've done for state corporations. So today we had a session for county human resource directors. We'll be doing other sessions, mainly now focusing on the private sector. I know some of my colleagues now in the other areas may also have missed out, but we'll continue working on this together with SHA to ensure that we reach each and every HR person, because we need to be very knowledgeable. We need to be at the forefront so that we can be able to inform our employees. So I wish to thank all the facilitators who have facilitated today from the Social Health Authority. I also wish to thank our PS, Harry Kimtai, for sparing a few minutes to talk to us. And a lot of thanks also to IHRM. The CEO, IHRM, is the one who offered this platform so as to sensitize all the HR practitioners. And unfortunately, she was engaged, couldn't manage to speak to us today. So we'll be doing more sessions as from next week. I've shared an email where if you have any concerns and those who wish to receive the training materials, you can just send your email through that email, which is training.medicalservices.health.go.ke. So at this point, I would like to request any
Please kindly
of
share
the
the email
participants.
address again.
I've shared it in the chat, but it is training.medicalservices@health.go.ke. So again, SHA will be organizing other forums and other meetings to sensitize any other person that needs to be sensitized. On the issue of the portal, that's where we're having a lot of challenges. And if you have challenges, please just call their call center number. You'll be directed or you'll be given somebody to assist you. There are issues about uploading of employees. So if you encounter those challenges, kindly call the customer, their customer care number, or they also have the customer care email, text, and somebody will come to your aid. Otherwise, at this point, I want to request somebody to offer us. Yes, Osoro? Osoro, you want to say something?
What is the customer care number?
Somebody from SHA, kindly, Osoro, if you have the customer care number, you can share.
Yes.
But I know it's there on their website. Yes, go ahead, Osoro.
It's available. Yes, I was saying the burning question of allowances, the understanding I've been made to understand is any allowance that is paid to an employee is deemed as gross salary, including overtime, a commuter, and many others. Even as we wait further guidance, please take it is any allowance, but in case we get further directions, we will be able to communicate. With those few remarks, the SHA contact number is 0800 720 601. I'll post it in the group so that people can be able to see it. I repeat, it is 0800 720 601. We have the call center that works 24 hours a day, 7 days a week, and 30 days a month. So please feel free to reach out in case of any challenges. Our officers in the branches and regions have firm instructions to support you as you navigate through the portal. With those few remarks, Chair, I submit.
All right, thank you very much, Osoro, for that input. Okay, there are still questions coming through the chat. Somebody try to respond. So I'll request any person to pray for us and thank the Lord for having granted us this session and ending successfully. Who is willing to put us in the hands of God?
Lillian.
Okay. Frida, you want to pray? You can go ahead. Frida or anybody else to pray for us?
Let us pray. Dear loving Master, Father, we thank you for this far you brought us during the meeting. We still have a lot to grapple with, Jehovah Lord, but we believe that with the support received and even the ones that we are going to receive, Lord, we shall be home and dry. We thank you for our facilitators. We thank you for IHRM.
We thank you for everybody that has supported this and is in support of this. Father, we pray, trusting and believing in the name of the Lord Jesus Christ. Amen.
Amen. Amen. Thank you and have a good day. A good day.
Amen. Have a good day too.